Well, welcome everybody. We're so excited to have our international ambassadors joining us this evening, and we're extremely lucky to also have Dr. David Weber from UNC giving us, he's part of our SHEA board, and I'm sure many of you maybe recognize him from our town halls that we do on Sundays. He is a true champion of that. He has been on every single one, although Dr. Hessler is also here, and she's been on almost every single one, minus her Super Bowl appearance. And we are very pleased to have you all here tonight. We're very pleased that we were able to continue the International Ambassador Program, although virtually is not the same, and we understand that, and we miss seeing all of you in person. We're very pleased to have you join us in whatever time zone you may be in, and we know it's a lot. And Dr. Weber is going to give us a short presentation about what we normally do with the international ambassadors is take them on a tour of a U.S. institution, and we're able to sort of show them the differences in how infection prevention works in a real live U.S. hospital. But this year, obviously virtual, we had to recreate that a little bit differently. And Dr. Weber stepped up with his team at UNC to really provide us this presentation of what it looks like. So I'm going to turn the mic over to Dr. Weber, and obviously you're all welcome to chat in the chat if you have anything, and the floor is yours, Dr. Weber.
Thank you. I really had fun doing this presentation, so I want to thank you all for taking time out to attend this. I want to certainly thank my medical center. They actually loaned me a professional photographer to take these pictures, and I really learned a lot by doing this tour. I hope you have as much fun listening as I had developing these slides. My goal really, next slide please, is twofold, which is to give you a tour and show you our facilities, but also to provide in some learning and teaching points here. So this is the UNC Medical Center. It is an academic medical center, part of the medical school, which is just behind the hospital from the University of North Carolina at Chapel Hill. It is part of UNC Health, which is 11 hospitals, 13 hospital campuses, more than 30,000 employees with more than 3.5 million clinic visits, 100,000 surgeries, and more than 5,000 medical staff. I will start off and tell you that the University of North Carolina is the oldest state public university in the United States. It was actually founded prior to when there was the United States, although the first students arrived around the time of George Washington. The medical school was established in 1952, and it remains the premier public hospital for the state of North Carolina. It includes the Memorial Hospital, which is the oldest one, the building to the left there, the large one, and then the Children's Hospital, Neurosciences Hospital, Women's Hospital, and the Cancer Hospital. It has about 950 beds and a whole variety of intensive care units and specialty care. Next slide. So some of the key infection prevention interventions I'll be showing you slides are, of course, the appropriate hand hygiene, the WHO 5 moments, as well as CDC guidelines, appropriate surface disinfection of rooms, disinfection, sterilization of shared equipment, medical devices, early identification and isolation of patients with known or suspected communicable diseases following the guidelines by CDC and WHO. There are special infection prevention policies for operating rooms, pharmacy, prep rooms, procedure rooms, and intensive care units. Importantly, the use of standard precautions with all patients to prevent contact with all potentially contaminated body fluids, which essentially is everything other than sweat. And of course, now in the days of COVID, we use what we call universal COVID pandemic precautions, which I'll talk more about. In terms of healthcare personnel pre-exposure prophylaxis for indicated vaccines, and at my hospital, mumps, measles, rubella, varicella, and influenza are required as a condition of employment, and then proper post-exposure evaluation for post-exposure prophylaxis and isolation if furlough if necessary. And that is a shared responsibility of healthcare personnel between infection prevention and occupational health. Next slide. So let's start off with some of the critical areas of the hospital I'll be walking you through. Hospital rooms, I'll show you clean and dirty utility rooms, airborne isolation rooms for diseases transmitted by the airborne route, such as measles, varicella, tuberculosis. I'll show you some slides of our COVID high-risk containment area, central sterile processing, which does sterilization, high-level disinfection. Our operating rooms, I'll talk to you about water damage, remediation, construction and renovation, and show you some slides of our pharmacy as well. Next slide. So let's start with the typical medical floor. And I realize, next slide, please, these may not be typical for you. So to the left is actually an observation unit where we keep our short-term stay patients there. I want to point out to you a couple of things. If you look, you'll see to your left, you see an isolation cart. And while you can't really see the signs there, you do see 2 isolation signs on the door. You'll notice between the 2 rooms here, I guess I can't show you, but you can see there's a little something hanging from the wall between the 2 rooms. That is our alcohol dispenser. And we have such a dispenser between every 2 rooms. So when you come out of any room at our hospital, if you turn to the left or the right, and sometimes both ways, you'll see an alcohol dispenser. You can see on the bottom another picture of some of the units, sliding doors in this case. And again, the alcohol dispensers to the left of each or right of each room. We do monitor hand hygiene compliance using an app on the phone. We have more than 1 million observations, excellent, and people rate when they see someone coming out of a room or going into a room, what we call clean in, clean out, appropriate hand hygiene use. You can see there, we went from back in 2013, 2015, from 82 to 96% compliance. And even though we were very good, we got to very, very good. And that was associated with a decrease in healthcare-associated infections. So the better you are with hand hygiene compliance, the lower your infection rate will be. You can see the 5 moments for WHO, but we simplified that to clean in and clean out. An important part of this is we're not just counting numbers. We're doing 2 things that are not generally done. One is we do this throughout the hospital, not just inpatient units, procedure units like X-ray, pulmonary lab, OR, and outpatient units as well. And part of the app is also to congratulate people and give them a very nicely done if they're doing their hand hygiene correctly. And if they're not, to in a respectful way, remind them of the importance of hand hygiene. And we monitor that as well. We don't call it feedback. We think that's a pejorative term. We call it just-in-time coaching because coaching is so positive. And more than 60% now of our numbers that we ascertain actually involve feedback, just-in-time coaching to the person observed. Next slide. So we also use, you can see one of those transmission-based precautions based on CDC guidance. We have several types, droplet for diseases like meningococcus and pertussis, which a simple mask is used. Contact for, say, MRSA or VRE, which is gowns and gloves. Enteric precautions, which we use for something like C. difficile and norovirus, which are a combination of contact precautions and enteric precautions. And here, when we do contact, you don't have to wear a gown if you're not going to have a close contact with the patient or environment, but for enteric, everyone does. And we use soap and water for those because alcohol is substantially less effective for non-enveloped viruses like norovirus and ineffective for C. difficile. By the way, I want you to notice that all our signs are in English and Spanish, since we have a sizable number of Spanish-speaking both employees at the hospital as well as patients. Finally, on the right, you can see our airborne precaution sign. Notice they're all color-coded as well to make it even easier and more straightforward, so they don't even have to read it after they get used to it. They can just see the colors there. And of course, for airborne isolation, they're in a special airborne room. I'll show you more about that. And they wear an N95 respirator. Next slide. So here is the room surfaces in our room. We know they're frequently contaminated, 25%, with important pathogens that can persist for days to weeks. Contact with these surfaces results in hand or glove contamination frequently. And so if healthcare providers don't do appropriate hand hygiene and wear gloves, then they will transmit infections from patient to patient. We also do terminal room cleaning to prevent the next patient from acquiring a disease from surface contamination. Evidence demonstrates that these contaminated surfaces lead to transmission. And if you're unfortunate enough to be admitted to a room in the United States where the previous patient had one of those pathogens, you have a substantially increased risk of acquiring that pathogen because of inadequate cleaning and disinfection of the room. And we know that when surface disinfection is done properly, it does reduce the risk of acquisition of these pathogens and decreases the overall risk of healthcare-associated pathogens. Next slide. So you can see here are one of our environmental service workers going in to perform the terminal room cleaning there. You can see the cart in front of the room as they first go in, and notice that they do have gowns, gloves, and mask on. I also want you to notice a few other things. You can see the cart has everything you need to do the surface disinfection. We make it easy. Go back one slide. Yeah. If you look to the right there, you'll see a sink. And to the above the sink, you can see paper towels for drying hands. And to the left, you can actually see the soap that we use. This is also can be used as an eye wash station. It's a little hard to see the yellow, but that's for eye wash. Notice it has foot pedals, so people don't have to use their hands and recontaminate them. I also want to point out to you to the right of the sink is what we call a splash guard. Just a piece of plastic that is vertical, and this prevents any splash from the sinks to the area further to the right where we'd be storing clean equipment. So whenever you have a sink that's next to something that could become contaminated, for which any patient devices, equipment would be placed, you want to limit the possibility of splashing contaminated water, and you want a simple splash guard. And you'll notice that there's a little hole to the right of the sink. That's for disposal of the paper towels. You should not be using drying mechanisms that blow hot air, since they actually lead to further dispersal of organisms. Next slide. There are other important surfaces in the hospital there. Curtains can become contaminated. At my hospital, we do, between patients, when we do terminal disinfection, disinfect the grab area of the curtain where somebody would grab it and move it, and we use a hydrogen peroxide spray there because of high effectiveness and low toxicity. Others are to use disposable curtains, or you, of course, could take curtains down and disinfect them. But the first is expensive, and the second is difficult. Dr. Donsky's demonstrated that floors can become contaminated with multi-drug resistant organisms. It's not really described well in WHO or CDC yet about what frequency we should be disinfecting floors, but we do routinely disinfect floors either with chemicals or with steam. Certainly shared patient items, in this case wheelchairs, but anything that goes patient to patient, blood pressure cuffs, x-ray cassettes, and others can serve for transmitting multi-drug resistant organisms. You can assess cleaning with fluorescent dye or ATP. We use fluorescent dye in our hospital for assessing cleaning of surfaces. You can use UV disinfection, chemical disinfection, but clearly the guidelines are, and appropriately so, that shared items should be disinfected between use. Fabric chairs we do not allow in my hospital. Dr. Noskin in Chicago did a nice study a number of years ago and showed patients in the little flimsy johnnies that you see them wearing, when they sit in those chairs, contaminate cloth chairs with vancomycin-resistant enterococci. If it's a porous surface like a fabric chair, you really cannot adequately clean it. And so all our chairs in the hospital are impervious. They're plastic or laminated wood or metal. We don't allow anything that is can be porous and allow a contact. I should say all of our beds, by the way, are covered. You can't see it under those sheets with a tightly wrapped plastic liner that goes completely around the bed and zips closed, because obviously body fluids on beds are quite common. Once those get into a mattress, there is no way, I'll say that again, no way to disinfect a porous contaminated mattress. They will grow Pseudomonas and many other organisms, and those types of contaminated mattresses need to be discarded. So simple plastic covering, which is covers it in all dimensions, is important. Next slide. So we have a surface disinfection bundle. The first is the standardized cleaning disinfection throughout the hospital there and a checklist. In general, our environmental service workers will clean most of the surfaces, but the nurses prefer to clean the highly technical equipment, particularly when patients in the room. If it's something like an IVAC device, an EKG monitor, the nurses prefer not to have EVS working on it for fear they might push the wrong button and lead to consequences to the patient. But it's not clear sometimes who's cleaning what. And so every unit in our hospital has its own checklist. The checklist for a pediatric ICU is different than the burn unit. It's different than the emergency department. Those checklists need to be agreed on by nursing and environmental services and specific to each unit in the hospital. Many people talk about highly touched surfaces in the hospital, and we've done studies, and you can in fact define a highly touched surface such as a bed rail compared to a low touch surface such as a light switch. But when you sample them from bacteria, they're the same. So we believe all touchable surfaces need to be disinfected daily. Terminal disinfection, complete cleaning and disinfection there, particularly clean and check the sink and toilet, damp mop the floor with we use detergents in the US, not just cleaning. It's always disinfection there. And we do monitor cleaning effectiveness with fluorescent dye with immediate feedback when things have not been done properly. We also use an ultraviolet light device for terminal disinfection of rooms that housed an MDRO patient. Next slide. And these are just examples of some of the UV devices that are available. These have been demonstrated to reduce infections. The major disadvantages are high costs. You still need to clean the room. Your patient can't be in the room when you do it. So if you're in a medical situation where all your rooms are multi-beds, that's a problem. But they have been demonstrated to reduce healthcare-associated infections and eliminate human failure to disinfect all surfaces. Next slide. And let's move now about preventing transmission of airborne pathogens. We've mentioned that's things like measles, varicella, pulmonary TB, but also includes avian influenza, COVID, MERS. And the key mitigation is use of an airborne isolation room. In the United States, that's defined as greater than 12 air exchanges per hour, direct out exhausted air, negative pressure, and an anti-room. And there are special pressure relationships for how you design those rooms, and those are listed to the right, and I've given you the reference at the bottom. Healthcare providers that enter those rooms wear an N95 respirator for protection, and depending on the disease, eye protection may be necessary. It's not necessary for tuberculosis, but is necessary for things such as COVID-19 that could be transmitted via the mucous membranes. Next slide. Here is just a look at, to the left, one of our, with the glass doors, one of our airborne isolation rooms, and then to the right, the entryway into our ante-room. If you don't have an ante-room, that's okay. It gives you a little extra protection, a place to gown and robe up, but you can, otherwise you just need, as always, to keep the doors closed. And then on the right, you can see into the ante-room with its sink and a separate door to the outside and door in. Next slide. Now, you can use fancy devices to measure the pressure. An airborne isolation room should be negative pressure, meaning the air flows into the room to protect people outside. Or you can use a simple tissue test. That's my hand you see there. Normally, if the air was even pressure, the tissue would hang down limply, completely vertically. You can see that it's actually being pulled into the room. This is a cheap, simple, and easy way of closing the door and testing just by the gap at the very bottom of the door that it's truly negative pressure. Or if the air tissue was going from right to left, it would show you that the room is positive pressure. And this tissue test was first described by my close colleague, Bill Rutella. Next slide. Every floor should have a clean utility room. This is where you put all your clean supplies. Notice some things, those shelves should be above the ground so that you can dust under them. They should be below the ceiling in case of fires so that the fire extinguishers work. Notice also that it's hard to see, but These are on shelves that are mesh. They're not on solid shelves like wood, so dust doesn't accumulate. It falls downward, ultimately to the floor where you can clean it. No dirty material should be stored in this room. Next slide. This is a dirty utility room. This is where hoppers, toilets, portable latrines, used dirty equipment get stored. You can see to the left is a hopper for which you put in waste. By the way, we should not be pouring things down any body waste. Urine, liquid stool, saliva should never go down a hand washing sink, by the way. They go down essentially a toilet where they go into the wastewater stream. Again, there is a hand washing sink to the right. And again, you can see the splash guard. So it is important to have access to clean and dirty utility rooms, and they need to be strictly used for those purposes. Next slide. Well, let's talk about our high-risk containment unit, COVID unit. Next slide. There are some hospitals in the U.S. that have special COVID units. They're very infrequent. Most of us have to sort of make do. Really, the keys there for prevention of communicable diseases, understanding the environmental survivability of the germ, germicide susceptibility, isolation. You have a hot zone, a medium zone, and a cold zone where people in the hot zone are fully in personal protective equipment. Then you have a warm zone where they can robe and disrobe, and a cold zone which is clean and all your clean equipment is kept. You need appropriate personal protective equipment. We use PPE monitors. We have someone there to make sure people take on and take off their personal protective equipment correct. This is only used for highly communicable diseases like Ebola and SARS. We have checklists and people are trained, but it still is useful to have someone there to help make sure they're taking on and off correctly, because that's the biggest risk to our healthcare providers is self-contamination, taking on and taking off their personal protective equipment. Obviously, you need to look into whether there is pre and post-exposure prophylaxis. In the laboratory, use appropriate biosafety levels. Ebola, for instance, is a BSL-4 agent, SARS-CoV-2 a BSL-3, and appropriate waste disposal. Next slide. So here are some pictures. This is the corridor going to our containment unit. Then you can see here, this is our donning doffing unit there with all the equipment there, separate from the outside. And then once you donned and doffed, then you'd actually enter our COVID containment unit. We ran out of rooms, which were airborne isolation rooms. So essentially, we treat the entire unit as a high-risk containment unit. And people are, when they're anywhere in the unit, they're in the appropriate personal protective equipment, gowns, gloves, eye protection, and an N95 mask or a PAPR. And then they have to have an appropriate doffing unit for when they leave. We've taken care of well over 1,000 patients in this one unit, and it's not our only COVID unit, without a single healthcare provider requiring COVID there. We have a medical regular floor COVID unit, an ICU COVID unit, an ECMO COVID unit, a COVID unit in psychiatry, a COVID unit in pediatrics, and a COVID unit in obstetrics and gynecology. Next slide. When you need to consider treating patients, locations for evaluating treating patients with highly communicable diseases, keep in mind that you need to separate those into those that are highly communicable by respiratory routes like SARS, MERS, and avian flu, and those by contacts such as Ebola. There is different guidance for personal protective equipment, waste disposal. So you do need to consider both types of isolation, what types of airflow you have. Ideally, you should be able to get into those units with direct access to the outside to minimize the risk of hospital transmission. Thank you. Next slide. Let's go to central sterile processing. Next slide. So I'll walk you through the steps. The central sterile services divided into 3 zones: decontamination, assembly, sterilization zone, storage and distribution zone. That's actually more closely seen on the right, where you come down with transport, then cleaning, disinfection, inspection, packaging, sterilization, transport, storage, clean utility room use, and then transport back. It's a unidirectional flow there from dirty to clean. Next slide. So here you can see to the left is where we would get our equipment would be delivered, and it would be initially rinsed off of any gross material, but it should be immediately kept moist for any contaminated material. Then it goes into the right into our automated washer disinfectors. Those are superior and have lower risk for injuries than doing it by hand. And you use an enzymatic cleaning agent and a disinfection. This will eliminate up to 6 logs of organisms and 5 logs of spores. So it's very effective, and cleaning should always precede sterilization and disinfection. So you go first cleaning, then initial cleaning, then washer disinfector. On that wall behind this, I'll show you now, next slide. So after it goes through the washer disinfector, it pops out in our sterilization unit. Those have directional airflow of clean to dirty. And this is our sterilization side there. And here is our steam sterilization, which is the most robust method for sterilizing objects and should always be used. To the right, by the way, and which you can't read, is a list of all the activities that are going on for tracking. And to the right are our low temperature sterilizers, and that's for heat and temperature sensitive items, but steam sterilization is the most robust method. And then you need to monitor how well this works with both temperature, with physical parameters, time and temperature, chemical parameters for disinfection, and ultimately biologic indicators to make sure your sterilizers are really working on appropriate cycles. And all of this needs to be really carefully documented. You really do not want errors of somebody getting contaminated equipment. Next slide. Once it's all sterilized, then it goes onto these trays, and under magnifying glasses, it's put back together. You can see on the right, then it's hung by the type of instrument, and people then, after they hang it in the right place, then they put together the surgical trays, which are unique to each type of surgery. Next slide. And then they are wrapped appropriately, and they stay sterile until they go into the steam sterilizer. They stay sterile until they are used. So we have not time-dependent sterile time, but it's really as long as the material is there, it is fine. And so they would then be wrapped and then sterilized. They get put on trays. Again, notice they're mesh. Notice they're off the ground. And then they go into transport trays that are closed to go to the floors so that the wrapping is not damaged and the sterility impacted on. Next slide. Well, we have a satellite pharmacy. It follows the same rules for making, preparing sterile materials. You can see here to the lower left is the door with restricted entry. And then there's a bench telling people don't go past that to the red zone. That zone is a gowning zone there. Then you pass through a door into an intermediate warm area. And then to the left and right, as you can see, to the right is the actual sterile preparation area. If you look through the doors on the back, you would see that little warm zone in between where people stay in their gowns. And then on the other side is another sterile room. One is for hazardous chemicals such as chemotherapeutic agents, and the other is for non-hazardous drugs. There are very stringent pharmacy rules here about how to gown and dress. Notice these people are wearing masks, head covers, gowns, and gloves. We're using special hoods. Those have UV light. They're chemically disinfected, but they're also sampled routinely for contamination so that when we prepare these drugs and compound them, they're truly sterile. To the extent possible, all compounding, anytime you enter and are making drugs, it should be done under these very stringent conditions. It really should not be done on tabletops in ORs or outside of ICUs. And of course, you can see the red bags for disposal of hazardous waste. Next slide. We'll go to operating rooms next. Again, it's a unidirectional flow. Staff only, don't come in. People are required in the semi-restricted zone. They're in clean scrubs or bunny suits, shoe covers, and hair covered. And then additional personal protective equipment is like masks are required if the procedures are in progress or sterile trays there. But the entire area, the corridors going from operating room to operating room are considered semi-restricted and not open to the public. Next slide. Here we have our hand washing sinks for surgical preparation. We also have ante-rooms into these rooms there. And here's a typical clean utility room. I want you to notice a few things. Everything is trying to be hung from the walls. The operating table is movable for improved cleaning. All the materials you can see on the wall, there's things not on open shelves. Everything is behind glass to further protect it from contamination. The operating rooms have greater than 15 air exchanges an hour. They're HEPA filtered direct with special airflow mechanisms, and you can see how clean this operating room looks after terminal cleaning. Next slide. This is our recovery area. There are no patients right now in the bays. They were on the other side, but for privacy, we didn't do it. This is sort of a typical recovery area. Again, each individual bay with proper monitoring, all clean. You can see to the right, this is part of our recovery room. Notice we have two rooms that we can put in that are there for patients requiring airborne isolation. These are airborne isolation rooms. They can also be used for contact or droplet there. Notice the sink to the left, the hand hygiene, and the special isolation cart outside those rooms. Obviously, you don't want to recover somebody who might have TB, chickenpox, measles in a multi-bed room. Next slide. Let's talk about water damage. Next slide. So this is what renovations area looked like before. You can see on the left, we had reports of potentially some mold, black areas. We went in and evaluated that. This is a courtesy of Mark Buchanan, one of our nurses who does do our work with remediation and looking at renovation and constructions. They took down the wall where they thought they saw some black material. In fact, there was water damage, and those black things are mold. So the whole room was sealed even before we did any of that work to prevent infections. They removed, and when things that are porous get wet, you cannot disinfect them. They have to be removed to go down to concrete and steel. So wallboard, fireproof material, insulation, all gets removed. So they took everything out. Now they're in the process of rebuilding it. Next slide. The leaking pipe was replaced. A new fresh wallboard was put up there, and then the entire area was cleaned before we allowed patients back in that area. Next slide. Remediation is well described in CDC guidelines. I'm not going to go through those. Really, the bottom line is everybody in the area needs to be in appropriate PPE if there's any contamination. Try hard to prevent any sharps injuries. Try anything that's wet to dry it out as soon as possible. Things that stay wet need to be physically removed. Contain dust appropriately there. And you clearly need a facilities plan for sewage intrusion, flooding, and other water-related emergencies due to internal problems like leaky pipes or external problems like hurricanes and floods. Next slide. Again, we're doing construction outside my hospital. The hospital is there to the right. This is actually a new surgery tower that's going up. And so again, all of our patients walking through this area to the parking lots are masked, and we had to make sure there was no intrusion of dust into any of our air systems there. You can see in a renovation area on the right how clean we keep those areas. We use HEPA filtered machines and routine daily dust and special airflow. We want to minimize any dust extrusion to where the patients are. Next slide. Why do we do that? That's because many outbreaks, this is from a paper that we did with our colleague, Dr. Kanamori from Japan. There have been many outbreaks related to renovation and construction. Generally, these are airborne aspergillus, occasionally zygomyces and other fungi, but they've been associated with dust produced by construction, repair, renovation, demolition. And so there are excellent guidelines from CDC and others about how to prevent this type of contamination and protect our patients. Next slide. There, and then we contain all of our units. So you can see any renovations behind closed doors with signs, tacking mats, and we visit those sites very frequently to make sure that all the remediation efforts we have in place are working. And we do have the power to hang up a sign and close down any site at any time for non-compliance. Next slide. A couple of things that you can do there. Even something as simple, which at our hospital they do literally every day. They're opening tiles to run new optic cables there. Those do represent a hazard if they're done in a patient room or outside of a patient room where the doors open. There is a fungi there, and particularly immunocompromised patients are at risk. So we use this glass cube you can see that people go in and they can then open the tile without contaminating it. The air from that glass cube is exhausted using a machine to the right. That is actually a HEPA filtration unit. You can see in this paper that Mark did. We did fungal sampling before, exhaust outside and inside. And notice how much higher the colony counts are inside there, as well as particles. So these type of units really work in protecting. So even something as simple as opening a tile, you need to have a policy about informing the nurse and infection prevention and mitigation strategies for protecting your patients. Next slide. One of the ways of risk mitigation is to use the so-called ICRA for infection prevention and construction projects. What you do is you complete this. You look at the patient risk group, low, medium, high, and highest. You look at the type of construction which is defined in the guidelines I've given you in the CDC guideline, and then you classify the work into 4 different levels, 4 different levels of mitigation, and then you can go look up for each one of these mitigation areas what types of prevention are necessary and should be implemented. Next slide. And we do require this at my hospital for any construction renovation units, and it's done by a combination of occupational health, infection prevention, engineering, and the construction people. So I want to end now. Thank you for my virtual tour of UNC Medical Center. All of our many colleagues here, around 13,500 just at the medical center, are devoted to providing excellent patient care, improving research, and teaching the next generation of healthcare providers. Thank you.